Hello, my name is Peter Bethwaite and I'm a cytopathologist here at Aotea Pathology. I'm part of a team of 6 pathologists who report cervical cytology. Today we're going to talk about aspects of HPV testing as it relates to cervical screening. For nearly 40 years we've been using conventional cervical cytology as a triage test to decide on what women we should send for colposcopic examination to identify and treat those women who have pre-malignant disease in their cervix. From a public health point of view, this has been a very effective approach in reducing incidence and death from cervical cancer. The problem though is that cervical smear test isn't especially sensitive as a test, and this means that women have to have quite a few of these cervical smear tests throughout their reproductive life for control of disease to be effective. In recent times it's been possible to develop an effective and cheap test to detect what we call high-risk HPV types. These are subtypes of viruses which are directly responsible for the changes in the cervix that we want to detect and treat. In many situations, the presence of these so-called high-risk HPV types in the cervix is a more sensitive test in deciding who we should send to colposcopy for detection and treatment. Importantly, a woman who tests negative for these high-risk HPV types can often be more reassured that she doesn't have any disease than she can from a negative cervical screening test. Also, we know that a woman who tests negative for a high-risk HPV screening test can be assured that that protection of a negative result will in fact last longer than it will from a negative cervical cytology result. So does the introduction of high-risk HPV testing mean that this testing will replace conventional cervical cytology? In the future, for many women, I believe this will be the case. At the moment, large trials are going on in Europe and Canada with just this aim, to see whether high-risk HPV testing can be used in place of conventional cytology. However, at the moment in our screening program we've chosen to use high-risk HPV testing in just a few specific areas. But I would predict that within the next 2 to 3 years we're going to see a much wider use of high-risk HPV testing. So what does our current use of high-risk HPV testing mean for the women concerned? Women will continue to come for cervical screening just as they have been. They will be invited and their smear taker will take a sample of cells from the cervix just as they do now and send it to the laboratory. The difference comes that for some women, as well as looking down the microscope and analysing the cells that we have been sent, we'll also take part of the sample and send it for a high-risk HPV test. So who are this group of women that we will select in the laboratory to have this high-risk HPV test? The women we really want to identify as part of our screening program are those that have a change that we call high-grade squamous intraepithelial lesions, or HSIL. This is the change that we want to identify, and we know that if left untreated can develop into cervical cancer. However, as part of our screening program we also identify a bigger group of women who have changes which are less than these HSIL changes. The problem is that amongst this group of women will be a few that when they actually do go for treatment will be found to have HSIL. However, most of the women who have this lesser grade of change don't need to go to colposcopy, and if they are left alone will tend to clear the virus infection and the changes on their own. It's among this group of women with the lesser changes that we really want to sort out those that we should send to colposcopy who have the presence of the high-risk HPV virus versus those that don't immediately need to go to colposcopy and can be left to deal with the virus on their own. We tend to use a cut-off of an age of 30 years for these high-risk HPV tests. Why do we do this? Among younger sexually active women, there is a very high exposure to HPV in the community, and these infections tend to be very short-lived. It's women who haven't cleared their HPV infection by the age of 30 which appear to be at an increased risk of developing cervical premalignant changes. Therefore, we tend to use the age of 30 years as a cut-off when it seems appropriate to use high-risk HPV testing. So what is the role of the smear taker in these situations? For these women, nothing will be different from routine. The smear taker will see these women in the normal way, take the cervical smear in the normal way and send it to the laboratory. In the laboratory we'll perform a microscopic analysis, and for some of these women we will identify this lesser grade of cervical abnormality. It will be the laboratory who takes the decision to activate a high-risk HPV test, and depending on the result of this, we will advise the smear taker of the recommendation. Normally, if the high-risk HPV test is positive, then our recommendation will be to send the woman for colposcopy. If the high-risk HPV test is negative, then the normal recommendation will be for the woman to be returned to the smear taker and a repeat smear taken in 12 months' time. So are there any situations where a smear taker can directly request the laboratory to perform a high-risk HPV test? Yes, there are. There are two specific situations where the smear taker can request the lab to do HPV testing, and the testing will be free to the patient. The first situation occurs in a woman who's had specific treatment for HSIL undertaken by a colposcopist or a woman's health service. In this situation, follow-up cytology and HPV testing in combination are used as a measure of the effectiveness of that treatment. We know that HPV can persist after treatment for a number of months, but it should be cleared by 12 months following treatment. By 12 months, the woman will have been returned to the care of the smear taker, and the smear taker will be requested to undertake a smear at 12 months following treatment. At that time, the smear taker should specifically request a high-risk HPV test as well as normal cytologic examination, knowing that the woman had had treatment 12 months before. The same situation will occur 2 years after that treatment. We call this a test of cure. The second situation occurs where a woman has had treatment for HSIL in the distant past and previously has been on a yearly cycle of returning for repeat cervical smears. A smear taker can request a high-risk HPV test when they do a cervical smear if the woman wishes to come off this yearly recall system. If the smear test and the high-risk HPV test are negative on 2 occasions taken 12 months apart, then the woman is able to return to 3 yearly screening. So are there any other situations where a smear taker can request the laboratory to undertake a high-risk HPV test? Yes, there are. A smear taker can in fact request a high-risk HPV test on any cervical sample that they send to the laboratory. I mentioned before the guidelines under which these tests are paid for by the screening program, and if a high-risk HPV test is requested outside of these guidelines, then the woman is going to have to pay for the test, and so it's important for the smear taker to inform the woman that she'll be meeting the additional costs of the high-risk HPV testing if it falls outside the guidelines. However, at this time it is not our recommendation for smear takers to request high-risk HPV testing outside of the guidelines. This is because really the clinical significance of testing outside of the guidelines isn't certain, and evidence-based recommendations on how to manage women having tests outside the guidelines isn't available at this time.